So, thank you so much for the invitation to be with you. It is an enormous privilege to be back with so many friends, old and new, I hope, in British Columbia. It was a privilege also to be a part of the welcome from Chief Campbell. I had the privilege in my previous national role to be responsible for diversity and equality across the NHS in England. I learned so much about the needs of different communities, so it was a particular interest and pleasure for me just in the tiniest way to be a part of that welcome. So thank you very, very much, Chief. But I mean it when I say it's great to be back in BC. I missed you. Now I know that's what presenters say. They stand on a platform and say, it's fantastic to be here in British Columbia. I love Vancouver. But I really mean it, and you're so lucky and so privileged to live in this place. And just to prove how much we care, sorry, back one. That's a photograph from my daughter's bedroom, of my daughter's bedroom, and the thing you see in the background is my two daughters walking along what I think is Long Beach outside Tofino, where we had the most magical and wonderful family time in your beautiful part of the world. And I love that photograph. It's my two daughters in a magical place, kind of walking off into the distance of their future, and she puts that on the top of her bed as a kind of reminder of happy times. So it's heartfelt, and also because whenever I'm here I learn so much, and it's going to be a privilege. I'm spending too much time on the platform today, but I'm really looking forward tomorrow to engaging in the program and learning from all the fantastic work that you do. Just in case it's not clear to you, you are genuinely internationally leading in much of the work you do. Some of the innovation you do, some of your work on your academy, on social media, on sepsis, all the other fantastic work you do is just so impressive to someone like me seeing, and probably even more important, although you will think that I'm being condescending, even more important, you are probably the best followers in the world I know. People who spot good ideas elsewhere and make them happen in your province. It's a very important talent that you have. And it's also wonderful to pick up the theme that Minister Lake mentioned about this theme of sustainability, something that we share, because we're part of a club. We're part of a club of societies that are trying to sustain the precious gift of universal healthcare. We didn't create it. It was created by people who came before us. Again, picking up Chief Campbell's idea of the baton going forward. I'm not sure why these slides are going automatically. I'm not doing a pechacucha, unless I haven't been told. So we have also a problem with this, which is just, so can we come back 2 or 3 slides? This is not a pechacucha, right? Would have been good to know if it was. I'm just going to press on, and we'll try and just back up a couple of slides and then figure out what my problem is with my clicker that I don't think I'm pressing. So we are in this club of people trying to sustain universal healthcare. Just because it's here doesn't mean it will always be here. It takes work to sustain it. It was created by people with fantastic vision and insight, and it needs extraordinary work to sustain that. It's part of a generational responsibility. My daughter was given, my youngest daughter in that photograph, was given an essay just before she left her senior school. It was I was kind of anxious about this, and it was an essay, I haven't quite got the title right, but it is, "What have your parents squandered?" Things that they had that you haven't got. You know, so I had a free university education. My daughters don't have that. You know, we had easily accessible housing costs to move into housing. My daughters don't have that. We had antibiotics without worrying about the fear of infection. We don't have that today. It's so easy to lose things that seem permanent, that matter, if we don't pay careful attention. Still the problem. I'm going to switch to pechacucha in a minute and just go, just do it without breathing, if that's all right. And so this responsibility that we have to work on sustainability is an intergenerational responsibility. I'm tempted just to blank it and just talk for a bit until you guys can figure out what my problem is. Okay. Let's just do something brave and blank it and see if we can just talk for a bit. And then when we figure out the problem, we'll come back. Thank you. This will work. Trust me, this will work. People who know me know that I come on these platforms and I try and be inspirational about cost, which is really difficult, about money in the healthcare system. It's relatively easy to get inspirational about quality, and you're doing astonishing, fantastic work about quality. But I want to try and be a little bit inspirational about cost in the system. You know the numbers. The numbers are really clear and straightforward. Around the world, healthcare costs are growing at around twice the speed of the wealth of our countries. It goes up and down a bit with economic cycles, but that's broadly the message. And the point about that is that it is factually unsustainable. Okay? You cannot spend 100% of the wealth of British Columbia on healthcare, or of any country. You cannot spend 50% because there are other things you've got to do. You've got to educate your kids and build roads and a whole series of other really important things to get right for this society. And it creates a paradox in the way that we talk about cost. Right now in the UK, we're going through a bit of a cost crunch. And you are a good person, you're a moral person, if you argue for more spending on healthcare. People think you believe in healthcare, that your values are in the right place, if you argue for spending more money on healthcare. But the problem is that if we do that year on year on year on year, if we argue for more and more and more, we will be the generation who destroyed healthcare for our universal healthcare for our kids and our grandkids. It's a paradox. It might be the right thing in any one moment to say we'd like more money, but over a generational time span, we have to argue for controlling costs because we care about healthcare, because we want it to be available to our kids. And that's why I try and get passionate about bringing cost and quality together. And so we need to be working on three things at once. Your jobs are tough enough working on one thing at a time, so this is a big ask, but we need to be working on three things at once. Firstly, you need to work on today, the work that you guys do every day in your hospitals and community, working on quality and safety and operations, bringing that together. But the point of that work is that it keeps things going today so that we can do the second thing. And the second thing is your extraordinary work on quality improvement. The first is operating the system, the second is optimizing the system. And by doing your extraordinary work on quality improvement, you're making further improvements. I would encourage you to think about quality and cost together in that work and not to see them as separate for the reasons I've talked about. But even in my view, even that work is not enough. It will buy time for the third thing. And the third thing that, if you look at the numbers, even with day-to-day good work, the benefits of quality improvement, even that won't move fast enough to protect universal healthcare, certainly for our grandkids, maybe for our kids, possibly even for ourselves in old age. And so we need to think about a third thing, which is some real innovation in healthcare. If the first is running the system, the second is optimizing the system, we need to think some brave thoughts about a different system. Helen Bevan, who many of us you saw last year, great personal friend of mine, talks about being a radical, about someone who rocks the boat without falling out of it. It's a great phrase, except that I don't really agree with it. She and I have had the most fantastic argument about it, because I've said, what if you're in the wrong boat? What if what you need is something going faster in a different direction? Rocking the boat's great, it may be the right thing now, but we need to think some deeper thoughts about the kind of system we might have. And that's what I'm going to risk doing with you today, which is just to lift our heads, even from the pressures of today, even from the wonderful work you're doing on quality improvement, and think about a system, so how we might properly change the system and do some extraordinary innovation. I'm going to use a little bit of a reference point, a little bit of an example. Here's a guy that I guess you've never heard of. He's a guy called Bob King. My dad was an engineer. His idea of a great day out was showing us a bridge. Yeah. Yes, great, Dad, yeah. What time are we going home? But it's kind of rubbed off on me. And Bob King's an interesting guy. In 1972, Bob King started in the US automotive industry to argue that they should be building electric cars in 1972. He was regarded not just as crazy, but as immoral. He was regarded as someone who was undermining an industry, who was undermining a petro-economy in the States. What he was saying was wrong, it was dangerous, it should be stopped. But Bob King's obsession was sustainability. He'd done the numbers. The numbers were known to everybody. Oil-based transportation. Transportation matters to people, but oil-based transportation was not going to be available for future generations. So he put to one side those and he started doing unpopular, difficult, not very welcome, unrewarded work on electric vehicles. And you know the story. The story is that as a result of that work today, electric and hybrid and hydrogen cell vehicles, the growth path is enormous. By 2040 in the UK, the government say every vehicle produced will be a hybrid vehicle or a non-emissions producing vehicle. Turns out that he was right, not because he was a visionary, but because he'd done the numbers and knew that we had to work on sustainability, even though it made people say that he was harmful. And if you say some of the things I'm saying today, if you can read my Twitter account in the UK, when I talk about cost control, people will say, Jim Easton is undermining the National Health Service. What the National Health Service needs is more money, more investment. That's how we measure the support of politicians for it. That's how we measure whether we're committed. And those people may even be right today, but they won't be right over a decade or 2 decades. And so we need to take the long view about the sustainability that's needed to make this system work. We need to think some, frankly, crazy thoughts and begin to make them happen that build for the longer tomorrow. Chief Campbell's idea of the baton passing from generation to generation. Build for the long tomorrow. So this is where I launch off into some ideas. It's hard to tell sometimes whether people are geniuses or just crazy. It's even hard when you look in the mirror sometimes to know. And I frankly have no idea whether the ideas that I'm going to talk to you about, which are things that I'm having a go at making happen, are the right things or not. It's kind of not the point. I'm not trying to persuade you that these are the right things to do. In fact, some of the things I'm going to say, some of you will hate. Okay? They may be right, they may be wrong. What I'm trying to say are these are the sorts of ideas and innovations and changes that we should be starting to work on now if we believe in the sustainability of healthcare. Not just optimize the system, a different system of care. So I'm going to share them. You may never talk to me again, but we're going to give it a go. So big idea number one. I think we need a system of hyper-prevention, a system in which we stop the people that, Minister Lake was talking about his dad, who become acutely ill. We all know the underpinning main problem of cost and quality in our healthcare system is people becoming acutely unwell and then needing acute care, very expensive, whereas they want to stay in their own home. And we need hyper-prevention. And I am, as lots of people I'm unpopular with in the UK, I'm particularly unpopular with a wonderful group of people who are public health doctors. And the reason I'm unpopular with great public health doctors is that I tell their story like this, which is that public health medicine in the UK is the branch of medicine that has saved more lives over the last 150 years than any other branch of medicine, but it is the lowest status branch of medicine in our society, possibly apart from psychiatry, which is another shocking admission about status in the way we think about medicine. In fact, I say to them, just to dig my hole even deeper, that public health had 2 fantastic interventions. One was Edward Jenner in the 18th century, developing vaccination, injecting unwitting strangers with cowpox. Pretty sure that wouldn't pass muster now, but turns out was useful. And the second was John Snow, the extraordinary Victorian physician in the 19th century who did some of the groundbreaking work on civic hygiene, water supply, clean water supply. Those 2 people have saved literally millions and millions of lives around the world. And what I say to my public health colleagues is, you're a little overdue for the next big change. Why don't they like me? It's strange. But I think it's there in front of us. And because what's happening in front of us is that the potential to monitor our health is growing rapidly. That's why you've got this challenge going with a number of steps. Millions of people around the world are voluntarily choosing to wear these devices that start to monitor, albeit relatively simple, aspects of their health, because the technology has now reached a price point. At the same time, all sorts of other technologies more on the medical side are being developed. This is the one we're using, which have finally reached the right price point. Simple, attachable monitors which monitor vital signs for people. 5 or 6 vital signs about movement, temperature, breathing rate, single lead ECG, heart rate in other words. Price point of these now in English pounds, maybe £50 for a 3-week battery life. That's a transformational change in terms of our ability to simply monitor people's health. But just sticking devices on people, just wearing things won't make the difference. And so my suggestion about a direction we're trying to go in is that we create a system in which increasingly large numbers of people, either voluntarily or people who are frail in our community or need to leave hospital but we're worried about their local situation, have access to simple monitoring devices. That those monitoring devices are monitored quietly in the background by data centers. You see, you can monitor people's divergence from normal. It's a little bit more complicated than that, as physicians in the room will tell you, but you can do it. You can monitor people's divergence from normal. And those data centers can pop up when that person has something we should be worried about, and then we can proactively intervene. We're doing this today. I run healthcare services for a large number of the prisons in our country, and prisoners are difficult people to get in and out of hospital. Trust me. They're also capable of turning almost anything into something illegal. They are the smartest men and women you'll ever work with. And so we just simply put some monitors on people, we spot them, and typically we find that when somebody is developing a more serious illness, and prisoners physically are usually 10 years in advance in terms of their ill health than people in the normal population, usually we're able to spot a week or 5 or 6 days earlier than we normally would that something is going wrong. It's not a huge amount of time. But getting upstream by 5 or 6 days means that you can make the intervention. You can do something simple with those people. So when you're thinking about those new community beds you're building, it's a fantastic thing. We're building some community beds. In our view, just having more beds isn't the answer because they just fill up. You need to be able to get people out, back to their home, to stop them getting into their beds in the first place. And it would be possible today with a system of large-scale monitoring and using devices. There is loss in this idea. There's loss in all of the ideas I'm going to say. There is a loss of the sense of the human touch in terms of machines monitoring. It's going to be a theme in what I talk about. But in my view, there may be a much bigger return than the loss concerned. So that's number one. Number two is a simple idea, and you're doing it here today, which is we're going to have to do something about social design to eliminate calorific surplus. It's not just that being overweight means that we're eating ourselves to death. We're also eating our health systems. We're literally eating our health systems by creating this tidal wave of diabetes and other diseases. And our society is built, designed, engineered to encourage it, not to discourage it. People are building buildings with escalators that go from floor 0 to floor 1. That's all they do. Of course, you need to provide proper access for people with disabilities, but it doesn't mean you have to take out every single step upwards that people need to take. And I think we need to change our whole aspect of design to put in simple physical exercise back not into gyms. Gyms are great, but into everyday life. We're seriously considering in my organisation, which has over 250 buildings, with the cooperation of our staff councils, making it a disciplinary offence to use the lift to go up one floor. It's kind of crazy, but it's a gift to people to change their attitude to their own health and well-being. It's a gift, and it's a tiny, tiny step of the sort of thing I think we need to for social design to eliminate calorific surplus. Okay, I've now gone where I can't advance at all. And another one, please. Here's one that you won't like. Automating medical knowledge. So the joy of my professional life, I'm not a physician, I'm not a nurse, the joy of my professional life has been working with doctors and nurses and others. That you are the most extraordinary, occasionally frustrating, but the most extraordinary, apart from the word occasionally, the most wonderful group of people to work with. So I say what I say because of my love for that work, not because I think there's something wrong with it. But the numbers don't work. The numbers don't work. In the UK at least, if you roll forward 20 years, it will not be possible simply to expand the numbers of doctors or nurses at the rate we need. The numbers don't work. You have to achieve some change. And part of that, I think, is automating medical knowledge. You see, doctors are the doorway through into medicine. It's a wonderful doorway, fantastic men and women, but it's a narrow door. It's an increasingly narrow door. It's increasingly hard for patients in the UK to find their way through because of workload pressures, because of the time available for people to make a proper assessment, to spend proper time evaluating that people. And the idea of the door just getting narrower and narrower and people finding it harder and harder to get that time isn't tolerable to me. And so we need to think about this idea of automating medical knowledge. There's a lot of work, and goodness me, in the UK we've made some spectacularly impressive mistakes. There's a lot of work on the big idea here being automating the patient record. I'm not interested in automating the patient record. I want to get access to medical knowledge and use it through systems to make an assessment of my health. It's what I do in every other part of my life. There already exist algorithms which in large part are more accurate than most or many humans in helping making a diagnosis given the right information. Those algorithms already exist, and big players like IBM and Google and Apple are working very hard to make sure they do. And I think in the future, most of our initial diagnostic interactions will be with algorithms. And then what we'll do is we'll talk to humans for the human part, where special judgment, special expertise, special advice about what that means for us is required. We see it kind of happening now, at least in England, in a very dysfunctional ways, that people use algorithms, they use internet-based advice, and they bring printouts into their physician's office, and the physician says, yeah, that's very interesting, let's start again. It's a dysfunctional relationship. But I think in the future we'll have much more automated medical knowledge. Again, I acknowledge there is loss here. There's something here that's lost about, I want to talk to a human being first time, every time. Every time I've got a headache, I'd like to talk to a neurologist. But I can't. I can't even talk to my family practitioner as regularly as I would want because the pressure on them is too great. Let's use humans and highly trained humans for the special things that really need humans. And let's stream off the other activity and do it as pre-work wherever we can. And there may even be gain here. There are certainly communities, and one of them, by the way, is a special community called males who are terrible at interacting with humans and put it off as long as they can. And so, I know it's news for you ladies, but it's true. And some of those people, our early evidence shows, choose much more willingly to interact with software to do some diagnosis than they do to make the effort, embarrassed as they are, to go and talk to a human being. So I think it's coming. It's already happening now. I operate quite a controversial service in the UK, or at least about a quarter of it, called 111, which is a system, a first point of contact for anybody with any disease, symptoms that they regard as non-serious, where they can dial 111 24 hours a day, 7 days a week, and speak to someone. Most of the people they'll speak to are not even clinicians. They're non-clinicians with extra training, operating a very sophisticated algorithm called NHS Pathways, with some clinicians who can provide extra advice. Whilst it has over 90% satisfaction and is deeply evidenced, it's very controversial in our country at the moment about whether it's a downgrading of care, whether a non-clinician with an algorithm can be a safe way of handling treatment. Because one of the things it does, by the way, is it makes all mistakes transparent. So when something happens, which previously would have been hidden in traditional care, it's very evident because we have a full tape recording, we have a full trace of what the algorithm did. But it's already happening today, and it means that professionals are going to be able to do the special professional thing, which is that magical combination of wisdom, judgment, experience, and human touch when it's really needed, not for the many occasions when it might be dealt with elsewhere. So controversial, but real. And also, by the way, we need to get off the hang-up of doctors doing all the craft skills. You're fantastically trained people. I don't know why you're obsessed with doing jobs that you don't need to be fantastically trained for. It's like I invite Rembrandt to come and paint a portrait in my family, and Rembrandt arrives, and I said, oh, it's great that you're here, it's fantastic, looking forward to the portrait, but you're a painter, right? Because my walls need a bit of a touch-up. Okay. Let's have the highly skilled people doing the highly skilled work. And let's offload, as these are you'll know these people in the Aravind Eye system in India, a country that's trying to invent access to an extraordinary growing population with very limited resources, that started with a different mindset, that said ophthalmologists are really important. Let's get them doing the really tricky operations on people's eyes. And where we can siphon off some of the other more craft-based procedures, let's get other appropriately trained, but not with 7 years of medical and all the additional training that doctors get doing those things. It's controversial, it's difficult, you might not like it, but we need to protect our most specialist expert resources to do the things that only they can do. Number 4, and it's come up today already, transforming basic care. If there's a place where the numbers don't work most of all, it's trying to get people, often on not very high salaries, to care for people in their homes. It's a huge problem across the world. And I believe that increasingly technology is going to play a part in basic care in people's homes. From the intelligent home, the thing that's just checking whether you're moving around okay, that your meal's been done, that your temperature and blood pressure are okay, those simple things, possibly up to and including robots. I tried to get a video. The country that's doing this best is Japan, trying to develop robots to assist in care in people's homes. I tried to get a video that's would really impress you of a robot. This is the Japanese robot. It scares me to death. Why have they put a polar bear's head on it? Also, if you watch the video, it doesn't seem to be modeled on a human being. It's modeled. I'm a child of the 80s. When I was trying to pick up girls, we thought the robot dance was really cool in disco. That's what it's doing. It's doing this weird version of the robot dance. It's very disturbing. So the technology may not be quite there yet. Okay, I don't think it is. But it's coming. And again, we've got millions of patients languishing at home, or even worse, not being able to be maintained at home, being escalated to care that they don't want for the lack of scarce human beings doing tasks in the home. And we should be pushing really hard for the technology that will enable people to stay where they want in their home. I was listening to the minister's story. My dad died of COPD, and in the end, he decided to kind of let go and die because he didn't have his independence. You know, that was what triggered for him the move into kind of a terminal period of his illness. He stopped fighting, and we need technology to make that happen. But don't watch the videos and don't buy the polar bear robot. Maybe not being there. Or that one. That's just frightening as well. And my 5th and final kind of idea for the kind of change I'm talking about, I find it hard to get the right description. It's about innovation at the back end. We get very excited about invention, crazy new ideas, new products. I've shown you one with these new devices. But I think we should be focusing even more at the back end of the innovation, and innovation at the back end, at the infrastructure level, at the things that join things up. So we've got an amazing technology that we're working with. It's just remarkable at the front end, which allows a family practitioner, a general practitioner in my company to be able to do a high standard consultation with around 70% of people anywhere in the country at any time. It's a fantastic technology. And it's a mark of what a small world it is, that when I came here to the Hyatt Regency, I found they're using the same technology here to connect up customers to the services in the hotel. It's this. It's called a telephone. It's a ubiquitous communications technology that exists today that actually we found, as many others have, that you can do around 70% of high-quality primary care interactions and close the visit on the telephone. Nothing particularly miraculous in that. What's important, though, is the engineering to be able to do that at scale. So we run 4 large clinical call centres for our 111 service, doing 8 million calls a year. And we're now also using that to allow patients from practices anywhere in the country to ring 24 hours a day, 7 days a week. If they choose to do their appointment on the phone, we can have the drugs delivered to your nearest pharmacy, and we can stack up those calls in a way that optimizes their effectiveness really great. Real benefits for remote rural practices. Now, I know that in England, what we mean by remote and rural is not what you mean in northern British Columbia. People say, well, that could be 20 miles. So I know it's different. But maybe that makes it even more important. Because in our scarce communities where we struggle to recruit GPs, what we need those people to be doing is spending their time, their scarce professional resources, with people who really need the expertise they bring, not just queuing up, issuing relatively routine advice to people in 10-minute appointments. And this service, which we're now selling increasingly to large numbers of GP practices, is an extremely simple example of building innovation at the back end. There's a lot of work to get those telephone calls in so that all answered as your local GP surgery, not some anonymous thing, even though they're all answered in my Southall call centre. There's a lot of work to do the plumbing that means that when the GP answers that call, your note, your patient note with the special issues on your patient note pop up in front of them, so they're at least as good as a GP that you didn't know in your local practice. It's back-end innovation. I often think about healthcare. If we're building future healthcare, we have too many people who are interested in architecture and not enough people who are interested in engineering. You know, cities with fantastic, glamorous buildings, but where the plumbing doesn't work or the electricity isn't delivered. We need to be working relentlessly on the underpinning infrastructure that allows simple technologies, including things like the phone, to work. There's a lot of companies in the UK interested in starting up video phone services. I'm sure that's true here. It's really interesting where that's going to go. We don't find that video adds a lot of value. It adds a lot of cost. It's very glamorous, but it doesn't add a lot of value. I think it's very interesting that most of us have got Skype or the iPhone version on our phones, but most of us don't use it very often because mostly the speaking is enough in most of our life. And the same is true for most, although not all, appointments. So simple innovation at the back end. We get great results. When we ask patients in advance to say we're going to introduce this service to your local GP, do you want to do it? Most patients are opposed because they see it as loss. Understandably, I want to see my GP face to face. When you go ahead and introduce it, the overwhelming reaction is positive. That people see that they get convenience when they want it and then time and personal contact when they need it. And that's the kind of difference we need to make. So these are about changing the system. These ideas are things that we're trying to do in our company, not the polar bear robot thing, we're not trying to do that, but the others we're trying to do. They're all strongly resisted, really strongly resisted by many colleagues, because of this deep belief we have that doing the right thing for healthcare means keeping the system the same. Am I okay for 5 minutes? Yeah. So we need to make some of these changes to start building for this long tomorrow. The work you're doing on managing today, the fantastic work that's exemplified in this forum about quality improvement, but also starting to back some ideas about changing the system, building for the long tomorrow. And I'm going to finish with two kind of final thoughts. It's slightly odd that it was very nice when it was kind of published that I was arriving. I got some emails from people saying, it's great to see you. You are going to talk about these two things that you've said before, aren't you? So I've happily agreed to do that. So this is like being in some kind of old 80s pop group that's doing its last tour, where people want you to do two of your greatest hits. So it feels a bit cheesy, but people have asked me to mention it, so I will. They seem to have some impact on people before. And they're very relevant both to what I've been talking about, to these new ideas, and also to your work on quality improvement. And the first is to say something about spread. And the reason why I rightly praised you so strongly earlier for being great followers, because we probably already know in quality improvement enough things to keep us going for the next 5 or 10 years that are great. Our problem is we just don't do them. We put so much value on invention and almost no value on the spread of ideas. We're obsessed with getting recognition for invention and not for spread. It's why I said what I said. This is the way I always tell the story. This is James Bond. Sean Connery is James Bond, the only real James Bond. Is that right? And the reason I show Sean Connery is I went on a course. It's now nearly 15 years ago, the most wonderful leadership development course run by the government in our country. And it was great because you did some leadership development with people from all sorts of different industries, the oil industry, banking. And one of the people on our program was a spy, which is very exciting. And he told us he was a spy when he got drunk over dinner. That's the last 50 years of English history explained right there. And, so it's nearly true. It's nearly true. There was a guy on a course, and he'd been a spy. He'd been a proper spy. And he was a fantastically interesting guy, and all the women were quite impressed, and not most of the guys as well. And he explained that when you're a proper spy, you usually have quite a short shelf life because people figure out who you are and what you're doing, and you become less useful. So you have to kind of do something else. So you can go and be like a spy master and run other spies, or you can do what he'd done and taken his super spy skills and gone and worked in industry. And he worked for one of the large multinational electronics companies, a household name, and he ran their counter-industrial espionage department. And he explained it was a multi-million-pound department stopping people stealing secrets about how to make better microchips. At that time, I was in my pre-national role, and I was responsible for something called the Modernisation Agency, our kind of national version of the Patient Safety and Quality Council. And I said, that's really interesting. I said, I run a multi-million-pound department trying to give secrets away. And people don't want to know. So it's funny, but it's a disgrace. It's an absolute disgrace. We tell ourselves a story that we care more about healthcare and the improvement in healthcare than anything else, but not enough to learn and implement from other people. I'm probably just talking about England. I'm probably not talking about British Columbia. When I worked in York, York's a good hospital, very proud to work in York, still live in it, beautiful city, you must visit it if you come to England. York did very well on most National League tables and we made it better, but we were 20 miles away from a hospital called Harrogate Hospital, and Harrogate Hospital was always topping everything. Did fantastic work. We woke up every day hoping they'd be found out for the liars that they were. It's funny, right? But what a disgrace. What a disgrace. We never once, until we were in real trouble, thought that what our real reaction should be was to ring them up, using that technology there, and say, you guys are doing some great work, can we learn? And until we do that, then we cannot call ourselves quality improvers. We can call ourselves, as I was, an egotistical person who wanted to get credit for invention. That's what I was. It's going on right now in England, between England and Scotland. Don Berwick has just set the cat amongst the pigeons by rightly, in my view, saying that Scotland is ahead of England in quality improvement work. The only way England can deal with that is by thinking that Scotland's like Harrogate Hospital to York, just hoping that they're going to be found out to be liars. What a disgrace. What a disgrace. Good news is it's easy to solve. Get over it. Go out and find it and model it and do it today and make a difference. And the second sort of greatest hit thing I was asked to mention, which again has come up today, is that we need to get over this addiction to rescue. This is a picture of the hospital I used to run, York Hospital, and the guy there was my nurse director, Mike Proctor, still a good personal friend, the day after the hospital set fire. I was asleep in my bed at 2 o'clock and the switchboard rang. I wasn't on call to say, we're awfully sorry to bother you, Jim. We just thought we'd let you know the hospital is on fire. We didn't know whether you want to come in. I said, I thought I would, yeah. And it's kind of funny now because everything was fine, but hospital fires are potentially devastating, terrible things. Guy well known to us with drug and alcohol problems had come potential overdose. We'd admitted him to observation. He'd woken up in a relatively psychotic state of mind in the middle of the night. He'd found the linen store, poured lighter fluid onto it, set fire to it. Burnt out the whole third floor of the hospital. 120 patients were evacuated. The last 2 were evacuated through real danger, smoke and flames gathering by 2 very young nurses. And a junior doctor found this guy who by this time had found a knife and was going around threatening people and subdued him. And all was well, all was well. And because of what happened, the traumatic effect, we applied for and got National Bravery Awards for those 3 staff, the 2 nurses and the doctor. And 3 or 4 months later, we had a fantastic presentational ceremony in the atrium of the hospital where we gave those awards, and it was wonderful, and the TV were there, and it was brilliant. And as we walked away from that ceremony, Mike Proctor said to me, Jim, it was brilliant what we did there. It was fantastic that we recognised those people. But what have we done for the people who've just gone 100 days with no central line infection? Because we're addicted to the rescue. We're addicted to the drama of it. We love it. In fact, if we love rescue so much that if we don't have problems, we'll create them so that we can rescue ourselves from them. That's a typical cultural experience in hospitals. People talk with great enthusiasm about how awful it is and how they've got through the day. And the problem with quality improvement is that what it creates is calm, ordered, routine care most of the time, including in the emergency room. It reduces the drama. And we love the drama. Watch healthcare portrayed on TV. It's about the drama. It's not about prevention and calm, ordered, routine care. So we need to learn to give value to calm, ordered, routine care. It was fantastic being a participant in the Healthcare Awards last night, where one of the recipients was a fantastic lady who'd done exactly that. One of the many things she'd done was to, I've forgotten how long it was, but it was some extraordinarily long period with no central line infection. That is rewarding, calm, ordered, routine care and unhooking ourselves from this addiction to rescue. So that's my final point. We love our healthcare systems. But sometimes the things we love, we have to change for them to carry on existing. It's my daughter's bedroom, my eldest daughter's bedroom. If you look carefully, the magazine on the right of the bed there is a bridal magazine. My eldest daughter gets married in September. My youngest daughter has just left to go to university. When you're a dad, or a mum or a dad, you know that the thing you love, you have to embrace it changing, including something leaving behind lots of things you valued in order to grow. And I think the same is true of our healthcare system. Sometimes we think that by arguing that it should stay the same, we're cherishing it. But we're actually committing it to its long-term failure. Even though the ideas about its change are difficult, we have to commit to them, and we love it by encouraging it to change, including in ways that we find difficult to manage. So thank you so much, apart from the technical glitches that I'm sure are my fault, for the opportunity to speak to you. Thank you for giving me the opportunity to congratulate you for your fantastic work on quality improvement, and please keep doing it better, faster, quicker, with more commitment, even when it's difficult. But also start thinking these new thoughts about a new system that in British Columbia will sustain this system for you, your kids and your grandkids, and create the long tomorrow. Thanks so much for your time.